Hi, this is Joe Cuthbertson here, and welcome to our fifth podcast looking at and examining COVID-19 and the impacts of COVID-19 around the globe. Today, we're talking to Dr. Michelangelo Bortolin. He's an emergency physician over in Italy, a long-time colleague of members of WADM and a fellow of Harvard University. Welcome, Michelangelo.
Hi, Joe, and good morning, everyone.
Okay, thanks very much for joining us, Michelangelo. We've at our recent and last podcast, we started with a bit of a look at the impacts of COVID-19 in Italy, and we thought we'd follow on with that theme, given your experience and knowledge over there. I wonder if you could give us a bit of an overview of how it all started in Italy.
Yeah, okay. First, good morning, and thank you very much for having me here today. And thank you for giving me the opportunity and your precious time to give this podcast. And then I reply to your question, how started in Italy? Well, the current situation in Italy started in February, but there had already been a significant event in January 2020. Indeed, at the end of January 2020 in Rome, 2 cases had immediately been identified and a diagnosis of coronavirus was confirmed. 2 Chinese citizens were promptly treated and put in isolation in the Spallanzani hospital in Rome. And fortunately, in this case, the spread of the coronavirus was prevented. Immediately afterwards, the Italian government decided to ban direct flight from and to China and to start checking traveler temperatures in all Italian airports in order to monitor and detect any suspected cases of coronavirus. However, days later, a case of pneumonia was detected in Codogno, in Lombardia region, and the diagnosis was severe pneumonia by SARS-CoV-2. The patient was a male in his 30s who didn't have a history of foreign travel in the previous period. And soon after, other cases were diagnosed in Lombardia region, and another cluster was identified in another region in northern Italy, in Veneto. So, the spread in Italy had begun. The Italian government on the 23rd of February issued a governmental ordinance to contain and manage the spread. A ban on entering or exiting a few small towns in the Lombardia and in Veneto region, where the spread started. The interruption of public events and shows, the closure of school and university, and also a shutdown was imposed on stores and office, and on several other commercial activities that are not essential to public utility. Then the government also imposed measures such as social distancing, quarantine, and self-isolation. However, 2 days later, on 25th February, there were already 322 cases. The largest number was in the Lombardia and Veneto regions, the regions where the first cases had been identified. And so, on the same days and on the following days, the Italian government issued further progressively stricter governmental ordinances until the lockdown itself. These ordinances required every citizen to stay at home and to move only for essential reasons, such as procuring food or for emergency situation, and moreover, quarantine for suspected cases of COVID-19 and self-isolation for the confirmed cases of COVID-19. And at the end, only workers involved in public utility activities were able to move from their homes to their place of work, such as healthcare professionals, law enforcement professionals, and workers in the food sector.
Wow, so like many other countries, the disease, it spread rapidly throughout Italy as it has in other places. What's the situation like there now?
Yeah, The situation now is that at this moment there are almost 170 cases of COVID-19. In Italy, a confirmed case is defined as being any person with a laboratory confirmation of the virus causing the COVID-19 infection, irrespective of clinical signs or symptoms. In the case of a confirmed diagnosis, the patient required isolation. It means fiduciary isolation at home if he or she doesn't need hospitalization, or isolation in a hospital healthcare facility if medical support is required. So, how does the system usually work in Italy in this moment? When a patient has symptoms of respiratory infection, such as fever or cough or shortness of breath, he or she is classified as a clinical suspect and is prescribed quarantine and self-isolation if they don't need hospitalization. Consider that over these weeks, this definition was constantly updated by the Ministry of Health. And in these cases, the diagnosis is confirmed by means of a positive nasopharyngeal swab to RT-PCR test for SARS-CoV-2. But we must also consider that in some cases, the nasopharyngeal swab was performed also on asymptomatic patient and was positive. Then we must also consider that patient required hospitalization at around 20%, and of this 20%, 4-5% required the intensive care unit. And in order to care for the many patients requiring hospitalization and the intensive care unit, elective surgeries and procedures were cancelled, and most of the operating room were turned into ICU. Until today, the deaths, the associated deaths to COVID-19 are around 22,000. And I think that the problem now is that we have a reduction of the cases, but reduction is not as people has hoped in the past week. And we must also consider that the lockdown was imposed on 9 of March, more than 6 weeks ago, and the lockdown restriction will have to be extended, I think, until the first weeks of May, and this could be a great problem for the country.
I see. So one of the challenges that many countries have faced is gathering information and understanding the data related to measuring both the spread and the impact of COVID-19. What can you tell us about the data that's been collected in Italy so far? What's it been telling you there?
Yeah, Joe, this is a very good question. At this moment, it's very difficult to draw a conclusion. But however, we can make some important observations. The first is that there are a large number of asymptomatic patients who haven't been diagnosed. At this moment, Italy is in lockdown, and people who are asymptomatic or paucisymptomatic remain at home, often without notifying the family physician of their clinical situation. Well, you can imagine the situation. For example, a student or a young man living alone in Milan who has cough, he stays at home during the lockdown and doesn't need to call the general practitioner or go to the hospital. And these cases are not notified to the surveillance system of the National Institute of Health. So, at the moment, we have an underestimation in the total number of cases, and therefore, all the other percentage should be recalculated. Then, it will be possible to make a more precise comparison with the other viral disease. Moreover, the data released from the Ministry of Health shows other meaningful points. For example, women are less affected than men. And what particularly stands out is the distribution of the age mortality rate. Around 95–96% are age 60 or older. Moreover, the comorbidities. It seems that the largest part of the deaths are of people older than 60 years with 2 or 3 comorbidities, such as cardiovascular diseases, diabetes, COPD, cancer, obesity, immunosuppression, and so on. And if we take a look at the data, there are another interesting point, is the overall case fatality rate that is substantially higher in Italy than other countries, such as China or Germany. And the question is why? There are several hypotheses that can partially explain this data, and I will explain 3 of these. The first, the population age. The demographic characteristics of the Italian population differ from other countries. In Italy, average life expectancy is more than 83 years old. Second point, the definition of COVID-19 related death in Italy. Indeed, case fatality statistics in Italy are based on defining COVID-19 related deaths as those occurring in patients who test positive for SARS-CoV-2 via RT-PCR, independently from pre-existing diseases that may have caused the death. And I think that this is an important point. But one of the most important points is testing strategies. Here in Italy, the policies to use the test to detect the infection, that is the nasopharyngeal swab, are different from one region to another. And in the beginning, there was the recommendation to test patients with more severe clinical symptoms who were suspected of having COVID-19 and required hospitalization. And this was due to a shortage of tests. And if we talk also about testing strategy, I would explain another point that I think it is important. I think that we should consider viral load test, but also serological test, and both as a combined strategy for today and for the future. Serological tests, in fact, can identify people who are infected and have already recovered from COVID-19, including asymptomatic patients. So, serological tests could be useful to identify, for example, who can return to work. Moreover, another important point that we can underline if we take a look at the data is that there are important differences of COVID-19 related deaths between an area and another area of the same region. And probably the differences in local policies and management have been crucial. And I will also have another important consideration to note about the situation in Italy. It is essential to consider the overall situation. So, I think that it is important to analyze this event in accordance with the concept of the disaster cycle. So, at this moment, Italy is in the response phase. However, the question is, what about the preparedness phase? And what was Italy's situation in comparison to other countries before this event started? And for answers at this question, I have checked some data. Italy's health system has 3.2 hospital beds per 1,000 people, similar to the US, Canada, and Spain. France has almost 6, and in Germany 8 hospital beds every 1,000 people. This data is from Eurostat in 2017. I don't have data from Eurostat regarding ICUs, but I can assume that the correlation would be almost the same. So, Italy 3.2, France 6, and Germany 8 beds for 1,000 people. I think that these data are really interesting, and anybody can understand that the overall number of physicians, nurses, and every healthcare professional that work in the hospital will be correlated to this number. So today, another question is, in the response phase, is Italy able to boost its hospital bed capacity? For sure, Italy can. Indeed, when a few weeks ago, the national healthcare system of North Italy was overwhelmed by the spread of coronavirus, the government organized an increase of 50% of NHS resources in every region of Italy. But consider the number. Anyway, even if in Italy now increased resources by 50% hospital beds will nevertheless always be a lower number compared to French and much less compared to Germany during daily activity. And this is a very important point, and I want to underline another time. This data means that Italy has less hospital beds during the surge than Germany or France during daily activity. And now it is very easy to understand why in Italy all beds are occupied and corridors and every areas in hospital are lined with patients. And so this is a crucial point in understanding how much Italy is now struggling, more than other European countries, even if this is the same event taking place at the same time. And there is also another important point to take into consideration. The shortage of hospital beds can reduce the effect of the flattening the curve thesis. Moreover, if hospital beds are just enough for daily activity, how long should the lockdown be? Or maybe the question could be, will the lockdown be sustainable for the Italian population? And another important concept, the national healthcare system in Italy now must take care of all the other patients, because now the attention in Italy, but also worldwide, is focused on coronavirus. But what about the other diseases? How do all the countermeasures for avoiding the spread of the coronavirus have an impact on the overall health of the population? And about this, for example, in Italy, the Italian Society of Cardiologists has reported that the number of myocardial infarction that was admitted in March to the hospital has dropped off at least 50% in comparison to the same period last year. So, another crucial question arises. If the lockdown can have an impact on the spread of COVID-19, consider a certain NHS and flattening the curve. How will it impact chronic diseases? And in the end, is it worth it?
Wow, thanks so much, Michelangelo. That gives us a really good overview, not just of coronavirus, but the healthcare system and how it relates to response to coronavirus in Italy. These sorts of insights are really important to healthcare professionals around the world, also grappling with this disease at this time. Do you have any final messages for your colleagues out there in healthcare as they're struggling with the same challenges that you are?
Okay, I always thinking that we do not reinvent the wheel. And then my final message is, it is very important to be prepared. And if the coronavirus has shown that we are not prepared, start to planning right now and following the data and a correct use of the data and make always a plan. Because the plan is very essential to understand how we are managing this situation. That is my final message.
Thank you so much, Michelangelo. That was an excellent overview. Your time is very valuable to us and valuable to WADA members and healthcare professionals out there. Thanks to everyone who's listened into the podcast series so far. We hope to hear from you again soon, and we'll bring you our latest update hopefully within the next week. Take care. Bye-bye.